So I'm going to talk about, we're doing this in a little bit reverse order, a little bit cart before the horse, but I'm going to talk about our experience with pancreatectomies. And this first slide shows the cut surface of a pancreatectomy specimen. Through a focal lesion, which is here, with the arrows, causing severe hyperinsulinism in a 2-week-old baby. This is 8 by 4 millimeters in size, quite small. And you can tell when you look at it, it's very difficult to distinguish from the normal pancreas. And if you do special staining for insulin, which stains brown, if you look at the junction here between the focal lesion here and the normal pancreas, you can see that indeed it lights up. This shows our approach, surgical approach at CHOP that we've used since 1998. Learned lessons from the Paris group, transmitted to us by Charlie Stanley. And for the diffuse form of AHI, small intraoperative biopsies are taken without the use of electrocautery. As I pointed out on Thursday, pathologists hate if you use cautery because it distorts the specimen. It makes it hard to make the diagnosis. To confirm diffuse disease, and then a near total pancreatectomy, 98% is performed, but only if the baby is not medically manageable. And we like to see babies with diffuse disease who are medically manageable. For focal hyperinsulinism, biopsies are taken to localize the focal lesion, and then a partial pancreatectomy is performed to completely remove the focal lesion. And you need really excellent pediatric pathology. So when we do the biopsies or excise the specimen, the whole AHI team is there at a multi-headed scope, and 2 or 3 pathologists, and our pathologists are now quite experienced and quite good. So I'm just going to review our experience briefly, sort of the layperson's version for focal pancreatectomy for focal and diffuse AHI, and 434 patients from December 1998 until just last week, using our multidisciplinary diagnostic therapeutic approach. And many of you know all the doctors and nurses who are involved. Susan Becker, or I guess it's going to be Lisa States, is going to talk about the world-famous PET scan, which we love. And if there's time, I'll not only assess the clinical outcome of partial pancreatectomy in infants with focal AHI, but discuss the role of surgery in diffuse AHI, and if there's time, in line and in insulinoma. So this shows our experience. 434 patients, 216 had a focal lesion. 5 were sent from elsewhere after having an operation in which a focal lesion wasn't found or excised. 187 cases of diffuse disease, which includes some unusual, unique forms of hyperinsulinism associated with, for instance, Beckwith-Wiedemann syndrome. 13 cases of localized islet nuclear enlargement, and there may be some patients, families here who are affected with this, and 13 insulinomas. It's interesting, I went through my slides and I gave a talk here, I guess it was in 2003, to the parents. At that time we had, I think, 38 cases of focal lesions. So we've grown quite a bit, and I think that we've gotten a lot better. So this is from the educational video that many of you have seen, showing the anatomic arrangements that are important for pancreatectomy. You can see the veins, portal veins, perimesenteric vein, splenic vein, this perimesenteric artery, the common bile duct, which I wish it was that easy to see in the operating room, the shared arterial blood supply between the duodenum and the head of the pancreas, which is important. And then the pancreatic duct, which in a baby, the diameter is less than 0.5 millimeters, tiny, 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 tiny. And we use ultrasound to help us find it if need be. For those head lesions that are big, that are close to the pancreatic duct, we do a head resection. We divide the bowel downstream and then do what's called, the medical term is a Roux-en-Y pancreaticojejunostomy. So to preserve the normal pancreatic body and tail. And I wish we could do it that fast. This shows our experience with partial pancreatectomy in 221 cases of focal hyperinsulinism. Equal distribution, as you would expect, between girls and boys. The age at operation ranges from 1 week to 14 months. The median age, which is the age in the middle, of 7 weeks. With experience over the last 18 years, I've gotten pretty good at either seeing with loop magnification or feeling, that's very important, the focal lesion, but Lisa states and the PET scan has really revolutionized this. The spleen is at jeopardy for these cases if there's a problem with the splenic vein, which runs behind the pancreas, but we preserve the spleen in all the cases. One common bile duct injury, which then involves a reimplantation into the duodenum. The range of pancreatectomies was from 2 to 98%, vast majority are less than 50%, and now we have many, many cases that are 2%, 5%, 10%, 2%, 5%. So that's good because I think we should maximally preserve the pancreas. More than half of the focal lesions are in the head or the neck, and there have been 35 of those Roux-en-Y pancreatic jejunectomies done, including 2 Whipple operations. I have done some laparoscopic resections for focal lesions in the tail. I'm sort of down on that now because when you do laparoscopy, you can't feel. And also you can't use intraoperative ultrasound to look at the pancreatic duct. And the dictum is we want to preserve as much pancreas as possible. 7 patients I would view as surgical failures, particularly early in our experience. And the early lesson was that accurate intraoperative frozen section confirmation of clear margins is imperative to make sure there's nothing left, there's not a tentacle left. And no patient is diabetic, excluding those that were redo patients. When you look at sizes of the first 38 of the 221, 27 were less than a centimeter in diameter. The smallest was probably 1 to 2 millimeters. And you'll see the distribution between the head, neck, body, and tail. And if one did a conventional near total pancreatectomy, there would be many cases where you'd actually leave the focal lesion. So it's important to be specific. And then 11 of the first 38 were large, and then you really need help with a pathologist to make sure you have clear margins. This shows an easily demonstrable focal lesion. It's reddish, it's raised, hard. I wish they were all like this, but they aren't. So this is the pancreas here, this is the spleen, this is the stomach. And this is a head lesion. Duodenum is here, it's the first portion of the small bowel, and here's the head of the pancreas. And this is a case that required that head resection, Roux-en-Y. An important lesson, as I mentioned, that in inexperienced hands, a near total pancreatectomy can be performed and the focal lesion is still in the kid in that residual head. So I won't go into that. Complications are shown here. There were 8 cases in which I didn't do enough the first time around. There was a little tentacle left. I think I just saw one of those families here. So for these, you just can't give in. You need to be willing to roll up your sleeves and go back. It's not the end of the world, but we will not give in. We will not give up. Small bowel obstructions are a risk, and this just shows technically what's involved in that head resection in Roux-en-Y. Here's duodenum, a gallbladder, common duct, big head lesion, head resection while preserving the blood supply to the duodenum, while skeletonizing the common bowel duct, which is very sneaky. It runs to the head of the pancreas. It's very, very small, very delicate, and then transecting the pancreatic body here, and then we bring up the bowel to do the anastomosis, which is quite precise, and we've had very good results with that. Diffuse disease, 187 cases, and this is for those who can't be managed medically, and I hope there'll be some future date in which all these babies can be managed medically. I hope that, so you better get to work, Diva, and others. 13 cases of diffuse disease in which there was diffuse involvement in Beckwith-Wiedemann. The outcomes are here, which I think Diva and others will discuss, including neurodevelopmental outcomes, 3 common bowel duct injuries that were recognized, no splenectomies, long-term risk of insulin-dependent diabetes, which I think Diva and Paul Thornton will address as well. And surgery is not a cure for diffuse disease, but can help prevent hypoglycemia and brain damage. Susan Becker and Anya Zada did this beautiful map. So this shows our patients, 434 as of last week. We're still working on Wyoming, North Dakota, South Dakota. If anybody knows any patients there, send them here. And of course, there's quite a few international cases too. Paul Thornton told me the other day they've had a referral from North Dakota, which is good. And the paradigm, which I think Diva and Paul will go through in terms of triage and which limbs children go down. So a multidisciplinary approach, specialists in pediatric endocrinology, radiology, pathology, and surgery for patients with the focal form of congenital hyperinsulinism can distinguish focal from diffuse disease, localized focal lesions, and permit partial pancreatectomy with cure. In almost all patients, our cure rate is about 97% now. Just want to mention, we've had focal disease, diffuse disease, and there's this additional entity that folks in Charlie Stanley's lab, and there was a very nice abstract at our meeting the last couple of days by Kara Budheng Singh for localized islet cell nuclear enlargement, or LINE, in which only a portion of the pancreas is involved. These cases usually involve a lot of biopsies and partial pancreatectomy. And so they're unraveling the mystery of this entity. There have been about 13 patients. Histologically, in the pathology laboratory on frozen section, it resembles the diffuse form of hyperinsulinism, but is distinguished by it affects only a portion of the pancreas. Older age at presentation, older age at time of operation, good outcomes with partial pancreatectomy. None of the usual mutations have been identified. But so it appears to be a distinct entity, and they're really getting to the mystery behind the cause. We've also done 13 cases in older children of insulinomas, which is sort of a focal form of HI, but it's not. And it's difficult to diagnose. Our team is really masterful. We really depend on the radiologists a lot. We don't have a silver bullet diagnostic test. This is much more common in adults, where endoscopic ultrasound, putting down a scope and looking at the pancreas through the stomach, is the best way to find these lesions. So we have to have sort of all hands on deck to try and find the location. And this shows our first 9 of 13 cases. And you can just shell these out. That's what enucleation means. And also, we depend on the radiologist in the operating room to use intraoperative ultrasound, because insulinomas are usually straightforward to see by ultrasound, which is usually not the case for the focal form of HI in babies. And this shows in ultrasound, and this is the pancreas, and this shows the insulinoma here, and then this is buried within the pancreas, and we could take a needle localization here and go right there, and then I know exactly where to go and shell it out, and the kid's cured. It's my favorite. And of course, you can all tell that we depend on the triad of patient care, research, and education. And I'm delighted to be here today and see so many families. Thank you very much. You're supposed to do questions.
Time for some questions. Anyone has any questions?
Yes. Sorry, my question, you mentioned the Roux-en-Y. I'm just wondering from a surgical point of view, as the child grows older, the 2 pieces will continue growing with the child at the same pace? Is there like side effects or whatnot as the child gets older? Because I was told there could be problems as far as like puberty and that kinds of issues after the Roux-en-Y. So I'm just wondering if that's an issue still.
Well, that's a good question. Our experience is still fairly young, of course. We've only done 35 cases, but that's probably about 33 more than anybody else in the world. The children need to be followed, of course. I just found out from Catherine Lord, who's done some of the follow-up, that 2 of the 35 patients in that Roux-en-Y group had a Whipple operation done because the focal lesion involved the area that's close to the duodenal wall with the blood supply. And those children, although they've preserved their endocrine function with the normal body and tail, they need pancreatic enzymes. So there must not be good drainage in those cases from the pancreatic duct. That's not been the problem in the other 33. Things should grow, and I've done pancreatic operations for pancreatic tumors in children with the same sort of approach, and it's not been an issue with regard to growth. So I don't believe what you were told is correct. the back.
I gotta bring it up, boys. Just as a follow-up to the Roux and Y question, what is the oldest patient that you had that was 3 to 8? Do you have that information?
12.
12?
12 years of age, yeah. I think, I might be, a minimum of 12.
Hi.
The baseball guy here.
Yes,
yeah.
and keep in mind, that's who's asking the question. So, in our case, the PET scan wasn't helpful for you to find the focal lesion. How do you, I mean, I didn't even have a chance to ask you, how do you find the focal lesion when that doesn't help?
That's a very, very good question, and I think Lisa, when she shows the PET scan information, might mention that. If genetics are consistent with a focal lesion, but we still have about maybe 15% of PET scans don't show a focal lesion, and so your child was in that group. So what we do there is do an exploration, expose the entire pancreas. I look and feel. I wear magnifying loupes to magnify things by a factor of 4. I'm pretty good at feeling things, but not all the time. And we also have the availability of intraoperative ultrasound to not only find the pancreatic duct, but maybe to help us find it. Usually it is not of help, although recently it was in a case that was 2 millimeters in size, buried in the pancreatic neck, and had a capsule to it so they could see the capsule. So it's really all hands on deck, and we're just prepared for a siege in the operating room. We are not going to leave the operating room. If all the biopsies are normal, I will keep biopsying until I find it. Never give in. Yes.
Hi. So 10.5 years ago, you removed 97% of my son's pancreas. And I'm wondering, does that mean that he has 3% of his pancreas now? In terms of growth, he was 5 weeks old at the time. In terms of growth, and also what's known about regeneration of pancreatic tissue.
So how's he doing now?
He was just, I don't know if it's considered diagnosed or declared diabetic a year ago,
Okay.
But he's doing great and is his diabetes is very mild. He's on 1 shot of long-acting insulin a day.
So I'm sure that both Paul and Diva may address this in terms of sort of long-term burnout of the residual pancreas, where it's like little factories, those beta cells are just cranking until they sort of wear out. We have seen cases, particularly in the early years, where clearly there was documentation by CT or MRI of pancreatic regeneration. But that regeneration would be abnormal cells. So they're not going to be normal cells. I'm asked sometimes, why don't you just bank the pancreas you take out, extract the islet cells, and then give them back at some point in time as an auto transplant. But those cells are sort of dumb cells. They're just going to crank out the insulin no matter what. So that's not a very good idea.